Hello, welcome to this presentation about a multidisciplinary approach to treat wearing off related non-motor symptoms in Parkinson's disease. I'm a psychiatrist and a professor of neuropsychiatry. So in my daily practice, I see a lot of PD patients with quite severe wearing off symptoms that often accompany with anxiety and depression and cognitive troubles. So that made me interested in this topic, and I would like to introduce some clinical vignettes and describe how we developed a new treatment and tested it for its efficacy. So let's first start with a real patient. This is Mr. P. He had Parkinson's for about 8 years and is using medication 3 times during the day and 1 before night. And what is very typical in his day is that about 1 hour before the noon medication and also 1 hour before the evening medication, he feels an increase in tremor, slowness of thinking, he's nervous, he has a negative mood, and that really impacts his quality of life. So the most obvious consequence is that he is avoiding going out of house, doing activities around the clock of 11 or 5, because he's anxious that he gets into trouble. So the off symptoms disappear quite soon after taking medication. And after medication, there's no peak dose dyskinesia. So this sounds as a very common daily practice situation, and I think most neurologists see this many times a day. So what would be your first choice strategy in this case? I think it's very clear. It's most practical to adjust the scheme of levodopa or increase the dosage or increase the number of times taking medication. So we talk about wearing off, and the meaning of the word wearing off is that it disappears slowly until it is no longer existing. So the effect of medication disappears during the time, and just before taking new medication, people feel the motor as well as the non-motor symptoms of PD. So this is a very typical pattern of wearing off during the day, with an alleviation of symptoms soon after taking medication and a return in symptoms just before the next time slot for medication. And this wearing off period is very often impacting the daily life of patients significantly. So the motor symptoms are very clear for most people. So we see an increase in bradykinesia, rigidity, tremor. We often see freezing and sometimes an end of dose dystonia. But in my clinical practice, I mainly see the non-motor symptoms of PD. So we see an increase in anxiety, a drop in moods, apathy, also autonomic symptoms and cognitive symptoms like rigidity and cognitive slowing. And it's important to realize that about 75% of the patients experiencing motor off symptoms also experience the non-motor symptoms. So a decrease in mood and an increase in anxiety is very often co-occurring with these motor fluctuations. So a very practical way of assessing these wearing off symptoms is the wearing off questionnaires. And there are different versions of the questionnaire. The 9 and 19 item versions are normally good for screening, and the 32 version is good for making a diagnosis. What is very typical is that you assess both the symptoms as well as the alleviation of the symptoms after taking medication. So anxiety is maybe the most prominent non-motor symptom in wearing off. And anxiety is also present in PD anyway. So when a patient shows symptoms of anxiety, it's important to assess whether it's wearing off related or whether it's not wearing off related. So in case it's wearing off related, it's very often due to suboptimal dopaminergic depletion, or at the later stage of the disease, we see more often wearing off related anxiety. But we also see a lot of non-wearing off related anxiety due to psychological factors like uncertainty during disease progression, premorbid anxiety disorders, anxiety due to cognitive decline, for instance, due to loss of overview, or symptoms of anxiety due to psychosis or delirium. So today I would like to focus on the wearing off related anxiety and distress. So if we think about the causes of anxiety in PD, there are many various causes. And so as I said before, I focus on the influence of the hypodopaminergic status, resulting in mental rigidity and anxiety. But of course, also the other causes of anxiety contribute to the wearing off anxiety, like a degeneration of the serotonergic system contributing to anxiety, the involvement of the limbic circuit, also the autonomic disturbances due to problems in the brainstem, and degeneration of the cholinergic system, causing cognitive decline and loss of overview. And also decreased flexibility to deal with off symptoms. So already after 5 years of diagnosis, more than 65% of the patients experience wearing off symptoms. So the more progression of the disease, the more off symptoms we see, but also the more dyskinesia. So the green, the good moments decrease over time. So it's very important to realize that wearing off is also caused by non-compliance of medication use. It's very often we see that patients complain about wearing off. Well, when you really check how they use their medication, they are not very strict in the times of medication use. So that's very often to check before you go on. So next patient is Miss F. She has also a diagnosis for about 8 years, and she has medication times 4 days plus 1 before the night. And very often she uses escape dosages of 62.5 milligrams disperse. She very often has off symptoms, is hyper aware of the sensations she feels in her body, is anticipating these off moments increasingly and showing anxiety. And during the on moments, she shows severe dyskinesias leading to weight loss. So this is a more complicated clinical situation. And then what would be your first choice? It's not so easy to just increase the dosage or increase the frequency of medication, because the patient is already using quite a lot of medication and is already showing a lot of dyskinesias. So what you see in these kind of patients is a vicious circle from motor symptoms leading to fear of falling, distress, avoidance, anticipation to the off periods, and intolerability of these. And because of the increase of distress, also the motor symptoms again increase. And this is a very complicated circle. So what to do? Medical doctors, of course, also always think about changing the medication, like increasing the dosages or the frequency of dosages, or to allow escape dosages during the off moments. or adding a dopamine agonist, or amantadine, or MAO-B inhibitor. So there are many options that can be tried. There are some recent randomized controlled trials focusing on the added value of the MAO-B inhibitor safinamide, focusing both on the motor and non-motor symptoms. And what you can see in this graph is that adding a MAO-B inhibitor will increase in more on time, but there is a side effect of an increase of dyskinesias. This is another more recent randomized control trial with 2 dosages of safinamide, also showing a more on time and a decrease in off time. And this is an reanalysis on a previous randomized control trial focusing on the effect of a MAO-B inhibitor on mood fluctuations during OFF. And then again, we see that not only the motor symptoms improve, but also the mood symptoms. So that already shows a very strong interconnection between motor and non-motor symptoms. But when trying to optimize a medication, we also see that there is a limitation. So some patients develop a severe dopamine dysregulation syndrome, previously described as a hedonistic homeostatic dysregulation. We often see it, it's about in 5% of the cases that patients develop this problem, and it's quite a severe situation with compulsive uses of dopaminergic medication beyond what is required to optimize motor symptoms, and despite very severe dyskinesias. So what you see is drug-seeking behavior and self-medication with higher doses to avoid these wearing off symptoms. And they seem not to tolerate these off symptoms, such as dysphoria, fatigue, anxiety, and anhedonia. And by using more and more dopaminergic medication, you see also psychiatric complications like mania, impulse control disorders, and psychosis. So we can't solve it all by increasing or optimizing medication. Of course, one can think about deep brain stimulation and duodopa, but also in those cases, patients have to deal with off moments. And what we thought about is how can we use other strategies to treat this. So me as a psychiatrist, my first focus would be to treat the non-motor symptoms like anxiety with cognitive behavioral therapy, exposure therapy. We know that exposure therapy is a very effective treatment for people with anxiety disorders. But exposure treatment is very focused on the mind, on the cognition, on the behavior, but is not really including the awareness of the bodily sensations, and is not involving the motor symptoms. My colleague, the physiotherapist, is focusing on dealing with the motor symptoms like freezing, but is not including the mental parts of the off. So while discussing this together, my colleague, the physiotherapist, and me, we thought we have to integrate these two parts. And we became inspired by our patients who seem to benefit from holistic approaches like Tai Chi, Qigong, yoga, body awareness programs, and mindfulness-based therapies. So inspired by the anecdotic positive experience by our patients, we thought we have to combine exposure treatment and psychotherapy with the physiotherapy. And that's how we developed this new treatment modality, what we call Beware, body awareness in the treatment of wearing off related distress. So what we thought is let the psychotherapist and the physiotherapist together approach the wearing off behavior. And I will discuss a bit what we do in a treatment and how we tested this in a pilot study, and we are currently running a multi-center study. So the first part is in fact psychoeducation. Psychoeducation is important to really get insight into the vicious circle. Be aware about the triggers, be aware about the bodily sensations, and also be aware what the bodily sensations do with the mind and the behavior. So in fact, every good treatment starts with education. Then the psychological part of the treatment is based on the acceptance and commitment therapy. So the basic idea is that it's important to focus in the here and now, focus on what the experience is, and see what you feel and what the meaning is of it. And then focusing on the values, the big values that are important for the individual, and see what can be done to focus mostly on the positive values. And in this way, encouraging to gradually participate in activities that they started to avoid because of the wearing off. So we combine these acceptance and commitment treatment elements with exposure treatments by using imaginary exposure. So by using exposure experiments, we bring them in the treatment sessions to the off situation, and then let them accept the off and focus on what is happening in their body. So this is the ACT part of the treatment. And then we alternate this within one session with movement strategies and moving on rhythmic music. So both the physiotherapist and the psychologist are working together in a group treatment with about 4 to 6 patients per session. So this new treatment modality we tested in a pilot study. It's published in 2017. It was a small pilot study. We randomized the patients in a treatment as usual. That's just a normal physiotherapy group treatment and the beware condition. This is the design. There were 19 patients in the experimental condition and 19 patients in the treatment as usual condition. They received the treatment twice a week for 1 hour during 6 weeks. So in total, 12 sessions. So directly after treatment and also 3 months after treatment, we tested different outcome values, and the primary outcome was self-efficacy. So we thought it was best not to focus on symptom reduction, because in a progressive disorder like Parkinson's disease, it should not be the goal to have no symptoms, but it would be more important to be self-efficient in these situations. So to deal with it instead of expecting that there will be no symptoms. That's not very realistic. So that's why we focused on self-efficacy. Here you see the study population. It was well matched across the groups, and the patients had quite severe PD. These are the results from the pilot study. So the primary outcome was general self-efficacy, and we see that there was no significant difference on the primary outcome measure. We think that in the end the measure was not properly chosen because the patients themselves had the feeling that the treatment was very positive. What we saw is that there was a positive effect on the PDQ-39, on the emotional well-being, and there was also an improvement in the balance time on the one leg stance test. And we saw a trend difference in the PDQ-39 stigma. That's an item about how they deal with stigmatizing symptoms like tremor. Important part of the pilot study was the qualitative reports by the patient researchers. So we involved patient researchers in interviews with the participating patients to get more information about what should be improved in the treatment for the second stage. So we got the feedback that they experienced the new therapy as very positive, with some, so 1 out of 5 patients found it burdensome to visit the clinic twice a week. So some patients really came far away, had to come by car, and it was quite intense. So we got the suggestions for some improvements. So instead of twice a week, they advised us to go to once a week, but to increase the time per session, so 1.5 hours instead of 1 hour, to increase the amount of homework and self-help material for practicing at home, and also involving caregivers in homework. So with this information, we now developed a Beware 2.0 and started a multi-center study in the Netherlands. So we increased the sample size, and we have 3 cities in the Netherlands where we currently run this randomized controlled trial. And instead of 12 sessions in 6 weeks, we now have 10 weeks with a weekly session of 1.5 hours, with more focus also on homework. And again, we use the same design with a pre-post treatment comparison and also a 3-month follow-up. This trial has been delayed due to Corona. We had to stop it for quite some time. In the meantime, now we are restarting, but due to that, we are delayed, and we hope to finish in a year's time. So the take-home message is that wearing off, including the non-motor off, really leads to avoidance, to low quality of life, and in some cases to dopamine dysregulation syndrome. And the wearing off requires a holistic approach. The approach that we have developed and are currently testing is a combination of psychoeducation, acceptance and commitment therapy, and physiotherapy. And this approach seems promising, but we have to show it in the ongoing multi-center study. So our PhD student, Iris Giele, is defending her thesis on this topic, Surfing the Waves of Parkinson's Disease, on April 23. And you can download her PhD thesis with multiple manuscripts about the interaction between motor and non-motor symptoms in Parkinson's disease. I would like to acknowledge all the colleagues that are contributing to this work, both in our hospital, mainly Erwin van Wegen and Iris Giele. Erwin van Wegen is the PI on the Beware trial, and Iris Giele is the PhD student, and also all the colleagues from the other centers contributing to the Beware trial, and of course our funders. So thanks a lot for your attention, and welcome to ask questions.